Welcome to UOA On Demand. I'm Ravi Verma, and I'm honored to be your moderator tonight. We're here to talk to you directly, the patient, about a very common problem, lumbar spine complaints. So we'll focus on some of the most common things that we see in the office and the population as a whole. Before we get into the topics themselves, I'd like to introduce my esteemed colleague. We have Dr. Matthew Mcdonald. Dr. McDonald is a board-certified spine fellowship-trained orthopedic surgeon who did his residency at Brown University in Rhode Island and his fellowship at Rothman Institute in Philadelphia. We're very lucky to have him here with us today.
Thanks for the introduction. Hi, everybody.
So let's get to the first topic. I figured it would be best to talk about something very common that happens, especially in the summertime with people being more active, is disc herniations. So, Dr. McDonald, how would a patient with a disc herniation kind of present to you in the office?
Usually in a lot of pain, to put it simply. Disc herniations are rewarding problems to take care of because patients come in terrible pain usually, and one way or another, we find a way to get them better. So usually a patient with an acute disc herniation comes in with a combination of back pain and often pain that travels into the butt or down the leg, down sort of a specific nerve pathway. Sometimes in addition to the pain, they might have numbness or tingling in their legs. Sometimes in the setting of more advanced nerve involvement, they might even have some weakness in a particular muscle group that can manifest as a neurologic deficit. Many times patient will come in and they'll describe a recent injury, like I was, shoveling snow or lifting a heavy dresser. But surprisingly, that's a minority of the patients. A lot of patients that come in with these symptoms have no idea what triggered it or caused it. And they're often perplexed as to, what may have triggered the onset of symptoms. But I always explain to patients, bad discs sometimes just herniate without an inciting injury or inciting event.
And then if somebody does end up coming to see you in the office with these complaints or these issues, what kind of things do you do to work up the patient diagnostically?
Sure. So we usually start with plain x-rays, which are done here in the office. A plain x-ray won't diagnose a disc herniation itself. We need an MRI to diagnose a disc herniation, but we can often rule other things out with an x-ray and get a sense of a patient's spinal health. What is the health of their disc? Do they have young-looking discs? Do they have older-looking discs? Is there a fracture? Is there a spinal deformity? Is there spinal instability? So these are important things that we rule out on x-ray. Most commonly, the idea of a disc herniation is diagnosed based on clinical suspicion. So if someone comes in with these new onset symptoms, I could say with pretty close to 100% certainty that this patient likely has a disc herniation. Eventually, we're going to want to order an MRI, which is a study to confirm a disc herniation. It's very rare that we order an MRI right away. One of the reasons for that is that a number of patients, in fact, the majority of patients with disc herniations, will actually get better with some initial basic treatment and giving this a period of time to try to see if symptoms will resolve with time. So we don't order an MRI right away. We initiate the basic treatment pathway first to give the patients an opportunity to get better. But if patients don't get better after a few weeks, the next step in terms of the diagnostic algorithm is to get an MRI, and that'll show us if there's a disc herniation, where in the spine the herniation occurred, the size of the herniation, is it causing compression of the nerves or not.
So when it comes to MRIs, what kind of things will we see in an MRI that you will point out to a patient that may have a disc herniation? So first, we can take a look at what a normal MRI disc segment will look like. And this is an example of that. This is a patient with a normal disc where the red line is going through. And you'll see here that this area in the front is the dark disc area, which actually has some white in there, meaning that there's some water and health and some turgor in that disc. And that there's no bulging, right? There's a very sharp, distinct line here that there's no bulging going into this area where the nerves would be. That's an example of a normal disc level. Now let's show you an example of something that is not a normal disc or a disc that's herniated. So then Dr. McDonald, can you tell us then what's going on in this particular image?
Sure. So this is an MRI of a patient that had a pretty large disc herniation. So the image on the left side of the screen is a side view, and the bottom or the base of the spine down there is the sacrum. And the first dark space above that is the bottommost disc, which we refer to as the L5S1 disc. And what you can see on that image is that there's a very large fragment of that disc kind of projecting out or sticking into the spinal canal. Now that's the spinal canal that the nerves are passing through. We actually get a better sense of what's that disc is doing in terms of nerve compression on a cross-sectional view. So that's actually the image on the right side of the screen. You have to imagine that as a patient, you're lying on your back, and if we kind of slice your spine in half and look through you from the bottom up, that's the view that we get there. So what we see is that there's a very, very large fragment of disc on the left-hand side herniating into the spinal canal, and it's compressing the nerve. In fact, Dr. Verma, if you want to point out the S1 nerve on the right side, which is free, versus the nerve on the left side is being crushed by that disc herniation there. So this is a patient that came in with both back pain, but more significant than back pain, they had very severe pain traveling down the butt, the back of the thigh, the back of the calf. They had some numbness and tingling on the outer part of the foot, and even some weakness and some difficulty walking because the calf muscle was a little weak.
Yeah, that's a very stark example, and I like to show patients their MRIs when they come and see me in the office for this reason, because it's very visual. You can see that, hey, look at these other levels where you have your discs well contained and they have good color and everything else. Here it's very dark. It's herniated out. It's pushing up against your nerve root, and that's where the driver of your symptoms and your pain are, particularly when it correlates with they have left-sided symptoms, and in this distribution, as you mentioned, down the buttock and the hamstring and into the calf.
And so this was one of my patients who we attempted to get better first with our typical, conservative non-surgical measures, but he remained pretty highly symptomatic. And after getting this MRI, we offered this patient a surgery. He had a same-day microdiscectomy where we took out that herniation. And I actually operated on him relatively recently. He's a few weeks out from surgery now. All his leg pain is gone. He has a little bit of mild back discomfort that's continuing to improve. And he's gone back to work. So he's pretty happy with how things are going.
So if non-operative treatments and therapy and things don't work, then what are the options to address this beyond that?
Sure. So yeah, you pointed out the initial step, which is an attempt at non-operative conservative treatment. We see if it gets better with time. While we're waiting it out, we try some medications to manage patients' symptoms like anti-inflammatories, Tylenol, muscle relaxants, sometimes a course of steroids. And we get a patient in a physical therapy program because that's often very successful. If that fails, we get an MRI to confirm the herniation. And there are basically two strategies or options at that point in time. One is the idea of trying a spinal injection, basically a cortisone epidural injection, which we don't do as surgeons, but we have a physician in our practice who's a spine interventionalist who does these. He can try a cortisone shot in the area of the herniation near the nerve that's being compressed. And sometimes that will bring patients a period of symptom relief if patients are trying to ride this out a little longer and to see if they're going to get better without a definitive fix, which is an operation. The final approach, as I was alluding to, is surgery. So I always tell patients with a disc herniation, one way or another, we will get you feeling better. We first attempt to get you better with the non-surgical approach, but if that fails, we have an operation that very reliably fixes this problem.
That's great. And so then the surgical options that we have here, are they considered, I guess, minimally invasive or same day type of surgeries, or are these bigger undertakings?
Yeah, I think that's a great question. The overwhelming majority of disc herniations are treated with what I consider to be a small, relatively minimally invasive operation called a discectomy or a microdiscectomy. It's done as a same-day surgery. Younger, healthy patients often do it in a surgery center, although it can be done in the hospital setting if necessary. It's done through a small incision in the low back. Usually that incision is just a couple centimeters, couple to a few centimeters in length. We basically make a little opening in the spinal canal. We remove the herniated fragment of disc. We make sure the pressure is off the nerves. That usually takes an hour or less. And then patients spend a couple hours in the recovery room recovering, and they go home the same day.
That's great. Are there any specific risks or things that people should be concerned about when considering this type of operation?
Yeah, I think first is sort of, the decision for surgery. If you're in debilitating pain and you're not getting better with non-operative measures, this is a relatively small procedure with a relatively quick recovery compared to other spinal procedures that can make you better. So don't feel like you have to suffer for an extended period of time because you're scared of the idea of spine surgery. This is an operation that's pretty low risk, although any operation does come with a set of risks. The most common ones to talk about are the idea of a recurrent herniation. Sometimes we'll go in and we'll remove a disc herniation, and the patient will get better for a period of time, whether that's months or years. But one thing that can happen is a disc can always reherniate. Once a disc is damaged once, it's never a completely normal disc again. So I always counsel patients to the idea that we're going to fix this problem for you at this point in time, but there is always a risk that that disc could become re-injured or reherniate in the future. And that's not necessarily a risk that the surgery creates. It's sort of a part of the natural history of the fact that this is a damaged disc. It's no longer a perfectly normal, healthy disc. And there is always a risk that that disc could reherniate. But for the most part, it's a common operation. Infection risks are very low. We operate near nerves, and we take great caution and care to work safely and diligently around those nerves so that they're not injured or damaged. Those are sort of the main risks to talk about.
Yeah. And then how long is kind of the recovery with something like this? I mean, how long before you're back to your activities as normal, or you're starting to feel like yourself again?
Yeah, so also a great question. So one of the nice things about doing this operation is that a lot of the benefits from the surgery are immediate. Okay, so oftentimes patients come into the operating room, they have horrible nerve pain traveling down their leg, and they wake up and that pain's gone. Okay, so they're already a lot better. Now, sometimes there's some lingering numbness that might persist for a period of time that might take a little while to get better. And unfortunately, that the surgery itself created a little bit of surgical back pain, but that pain is managed pretty well. Patients will take different kinds of medications to manage the pain. We use a multimodal approach, which includes Tylenol, anti-inflammatories, muscle relaxants, often some opioids, but we try to really minimize that. Patients will do that anywhere from a couple days to a couple weeks, but they generally wean off these medications pretty quickly. And that surgical back pain tends to be much more manageable than the horrible pain that they had from the disc herniation. We encourage early mobility, right? We want patients to get up and start walking around right away. Walking after spine surgery is really important. It facilitates a smooth recovery. It minimizes your risk of, complications from being bedridden too long. So we encourage getting up, moving around, and walking from day one. We, ask patients to protect their back for the first few weeks after surgery. Things like repetitive bending, heavy lifting, things like that, we caution them to avoid for the first few weeks after surgery. But the recovery after spine surgery is really a gradual, progressive return to normal activities of daily living as your level of comfort allows you to.
A lot of times people will ask about, how long will I be out of work, for example. I try to tell patients that, if you have a desk job or a sedentary job where you're not doing a lot of, like you mentioned, bending, lifting, or twisting, that you can get back to work relatively quickly. I would say usually within a couple of weeks. If you have something of a more manual job, that maybe it takes more on the order of 4 or 6 weeks to do so. But people are generally recovering from this quickly and pretty well, and are getting back to their activities as they desired fairly quickly.
I think that's a great point. And this is a surgery that we do in athletes sometimes too. That's one of the cool things about being a spine surgeon in this condition in particular, is it afflicts people across the entire age spectrum, from teenagers that are high school athletes to patients that are in their 70s or 80s. So This is a surgery that we do on athletes from time to time that are at, sort of the high school or collegiate or, or even beyond that, level. And, in athletes, it's a much more sort of, guided, sort of measured return. We start with, return to aerobic conditioning first, followed by gentle weightlifting, followed by return to contact sports, if that's involved in your sport. So, for athletes, a lot of considerations are made around the idea of, are we mid-season, or are we going to do this on the off season and try to get you ready for the next, when practice and training starts for your upcoming season. So those are often considerations that we take. So full return to athletics is closer to 3 months. But most adults who, like you mentioned, work sedentary jobs are back in a couple weeks.
Yeah. I think it's a really important aspect of just the spine care we deliver overall at UOA, is that, it's a very personalized, tailored approach based off of your own activities and demands and things that you do and things that you don't like to do. And that's an important thing. There's not a cookie cutter, one size fits all approach, depending on all these other things that make you individual.
Sure. One question I get all the time, and maybe I'll bring it up for the benefit of our viewers, is they often ask, do I need physical therapy after this kind of surgery? So I have my opinions on that. I'm sure you'd be happy to share yours, Dr. Verma.
Yeah, post-operative physical therapy, I think it depends on how well people are recovering. Sometimes people recover very well, as you mentioned, and they wake up with the pain is improved, they're walking around better, that post-surgical back pain kind of resolves over the course of, a couple of days or weeks, and they're doing great, and they're wonderful. Sometimes because patients have limited their own bending, lifting, and twisting because of their ailment, and then we've limited their bending, lifting, and twisting for 4 or 6 weeks after their surgery, their back gets out of shape and deconditioned, and so they would benefit from some kind of core strengthening or back strengthening exercises. So that's generally what I tell patients, is that, if at the 6-week mark, you're still not moving around so well and everything else is going okay, then maybe I would initiate some therapy, gentle exercises at that point. But as you mentioned, everybody has a different feeling or thought process on that.
Sure.
One of the things I always get asked also is, is there something that people can do to prevent this kind of thing from happening? Why does this happen to person A, but not person B? Is there something that they did wrong or that they could do to prevent it in the future?
So that's a tough question to answer. For the most part, I don't think that there is a ton that one can do to really minimize the risk. Okay. Typically herniations occur in the setting of some sort of acute traumatic injury, like a major sports injury or a car accident or a major fall. Obviously, we all spend our lives trying to avoid major injuries, so there's nothing additional to do there. But the overwhelming majority of discs that herniate, it kind of just happens to discs that are a little aged, they're deteriorating a little bit, there's some wear and tear, and sometimes it's just these very benign life activities that cause it, like you bend over to pick up some laundry or something silly like that. So there's not a ton you could do, but there are some, I think, general concepts to promote, good spinal health. Maintenance of a healthy weight is definitely an important thing. Proper lifting mechanics becomes an important thing. So, if you have to lift something off the ground, squat and lifting with your legs is better than bending forward and trying to lift a heavy weight, particularly if the object is out in front of you. So that can become an important consideration. One thing that is also bad for our backs that we're all sort of guilty of is sitting too much. So, I encourage patients who sit for extended periods of time throughout the day, whether it's, work related or just, habitual, to, as best as you can, try to modify that behavior. A lot of employers will allow patients to have standing workstations or alternating sitting standing workstations. Get up, move around, walk as much as you possibly can.
Great. All right, so that was a great topic and discussion about disc herniations, but now let's move on to another very common topic that affects people in their back, and that is spinal stenosis. So how would spinal stenosis or arthritic changes present in a patient, Dr. McDonald?
Yeah, so lumbar spinal stenosis will more commonly occur in a patient that's middle-aged or older, because it usually develops secondary to age-related changes in the spine. Although I'll mention it does not exclusively occur in that age group. You know, sometimes younger people could be affected. Um, Patients with lumbar stenosis can present in different ways. One of the most common presentations of spinal stenosis is pain and or numbness and tingling that travels down the legs through the buttock area, particularly down the back of the legs. That is often worse with walking, and patients will actually often describe this sort of walking intolerance where symptoms feel worse when they walk, and they often need to bend forward to relieve these symptoms or sit down to relieve the symptoms. Patients will often describe this kind of sense of fatigability of the legs as they're trying to walk. So the majority of patients with spinal stenosis present with a combination of back pain and this radiating leg pain that I was describing. There are some patients who present with this walking intolerance, but it manifests more as back pain. So the walking intolerance that occurs with spinal stenosis is referred to as neurogenic claudication. And some patients just get claudication that manifests as back pain. But one of the major keys to the presentation is that it's bad to stand and walk. And patients will commonly say, hey, I feel better when I sit. If I'm in the supermarket, I can lean on a shopping cart and walk for 20 minutes. But as soon as I let that shopping cart go, 5 minutes in, I got to sit down and rest. So that's a common presentation that we see.
And then when it comes to these patients who present with this, what is different, or what do you do for the workup of these patients in terms of diagnostically?
Yeah, so the workup is similar to other spinal conditions where we start with plain X-rays. A lot of times the plain X-rays for this condition are a lot more valuable in terms of cluing us in terms of, one, that this patient is likely to have spinal stenosis, and kind of secondarily why they might have spinal stenosis. So, spinal stenosis basically represents narrowing of the spinal canal. So if the spinal canal is a tube or cylinder that should be open like this, spinal stenosis means that space has become restricted or narrowed and the nerves can get compressed inside. One of the most common reasons to develop spinal stenosis is the progression of arthritic changes over time. And what we can do at some point is show an MRI that it kind of explains this. There's arthritic overgrowth of the joints that start to close off the spinal canal. So when we get an X-ray and we see a lot of arthritis, or we see anatomic findings that suggest that the patient has a small spinal canal, and patients come in with symptoms that are suggestive of spinal stenosis, we can usually predict it just based on the X-ray and the patient's clinical presentation. There are a lot of other structural changes that could occur to the spine as a result of arthritis as well that are likely to result in spinal stenosis. And one of those conditions is a condition called the Spondylolisthesis, where we might see vertebral bodies move and shift out of place. And that's another finding that we could pick up on a plain X-ray.
Yeah, and that's really valuable. This concept of a slipped vertebra, or this spondylolisthesis, can be really visualized well on an X-ray. It's actually better visualized on an X-ray than an MRI, and can clue into a cause for somebody's back pain, and also potentially the cause of their spinal stenosis, which could be causing some shooting pain into their legs or elsewhere. So it's very helpful to do that.
And then after the,
sorry.
I was going to say, after the X-ray is obtained, usually the next level of a diagnostic workup is a more advanced imaging study of the spine. The preferred way to do that is with an MRI. An MRI gives us very valuable information in terms of characterizing spinal stenosis. So that's the preferred study to make the definitive diagnosis. There are patients who can't get MRIs for various reasons, metal implants, pacemakers, et cetera. And we have some other ways of evaluating spinal stenosis, either through CAT scans or CAT scans after a dye is injected into the spinal canal. So those are the most common ways.
Yeah, I think that's really helpful. And then I think we actually have an MRI here that we can talk through and see what would look like. So let me pull that up for us here. So this is an MRI of a patient with spinal stenosis and actually a spondylolisthesis. So Dr. McDonald, I'll let you talk us through what you see here.
Yeah, this is a woman who was in her mid-60s. The image on the left shows that the two bottom discs are in rough shape. And the way we know that is if we look at the upper disc, they're tall and they're a bright gray, showing that they're healthy. They have a lot of water content, which is characteristic of a normal disc. And we contrast that to the bottom of the spine where the L4, L5 disc there and the disc below that, which is the L5S1 disc, are very dark, very collapsed in height, very degenerated discs. So that's just one of sort of the MRI findings suggestive of degeneration and arthritis. One of the other major notable findings on that side view MRI that we're looking at is at L4, L5, you can see that vertebra L4 has shifted forward or slipped out of place on L5. And that's this condition that we were referring to called a spondylolisthesis. It can happen as arthritis afflicts the spine. It can cause some of the joints to become a little loose or a little incompetent, and this can develop over time. It's very common that when this condition develops, it's associated with spinal stenosis. And so if we look now to the image over on the right-hand side of the screen, okay, and we compare this to what the spinal canal has looked like on some previous imaging studies that we've looked at, what we see on this cross-sectional image is that the joints in the back of the spine have overgrown, and they've basically grown into the spinal canal, and they're starting to close off the spinal canal. So this woman who had a very large, spacious spinal canal at her other normal, healthy levels had significant narrowing of the spinal canal at this level at L4, L5, and what we would probably characterize as moderate to severe stenosis.
So based off of the diagnostic workups that you do, what are the treatment options you go to first before considering surgical options?
Yeah, so like a lot of spinal conditions, we attempt to treat it first with non-aggressive conservative measures. And the funny thing is patients always ask, well, if I do physical therapy, is it going to make my MRI look better? And the answer is no. But it is important to realize that a lot of these conditions develop gradually and slowly over time and can exist with either no or minimal symptoms. And if you come in with a few weeks of symptoms, it's very likely that if we got an MRI before you had symptoms, it would still look equally as bad. So what I always tell patients is we try the conservative stuff first, and we see if through the conservative treatment measures, we could calm symptoms down and get the condition to a state where it's either not symptomatic or it's minimally symptomatic and you're managing okay. And so we do that through our usual approach of physical therapy, Tylenol, anti-inflammatory medications, sometimes steroids. If those strategies fail, sometimes we'll try spinal injections like epidural injections. And I've seen many patients with spinal stenosis remain mildly symptomatic and live with it for an extended period of time. But unfortunately, spinal stenosis can be, for many patients, a very debilitating condition. One of the most challenging things about spinal stenosis is the amount of functional impairment it causes patients, because patients are so symptomatic when they're standing and walking and trying to be mobile and active, is that it kind of forces patients to become inactive and sedentary and less mobile. And they start to give up activities that they enjoy doing. Their decreased mobility can cause, declines in other aspects of their health. So unfortunately for patients that are debilitated by this, we have surgical treatment options that can fix this condition. And this is a condition that has historically very good, reliable, reproducible outcomes with surgery.
Yeah, I think it's really important, at least on the topics of all the non-operative modalities here. A lot of patients will come and say, hey, listen, my narrowed, canal, as you pointed out, isn't going to get unnarrowed with physical therapy. So why are we even bothering, right? Or I did physical therapy 5 years ago when this happened and it did nothing for me. So why are we even bothering? And I always try to remind people that, like you said, this is a degenerative condition that has happened over the course of many years or decades. And, your 1 month of exacerbation or flare up may not be where you are if we can get you over the hump and get you back to where you were a month ago. And, right. We wouldn't want to rush somebody into some kind of a operative intervention if with some conservative measures and some exercises, strengthening and things like that, their symptoms will go away and the flare will subside. So I think that's a really important aspect, and it's a question that I get asked all the time by patients. So let's say physical therapy doesn't end up calming down the flare, and some epidural injections are undertaken. They give some relief, or they give no relief, or not long-lasting relief. So then what are the kind of the surgical options that can be undertaken to address this issue?
Yeah, so this is a little bit more of a challenging topic to discuss because there's no one correct surgical approach to fix spinal stenosis. Um, the concept is that we want to create room for the nerves, and we want to do what we call a decompression, decompress the nerves or the spinal canal and get the pressure off the nerves. The most common way of doing that, particularly when the stenosis involves the central spinal canal, which it does more commonly, is a procedure called a laminectomy or a decompression. And the extent of a laminectomy or decompression, and what I mean by that is patients might ask, well, how big is the incision? What's the recovery like? Can I go home the same day, or do I need to spend a night or two in the hospital? The extent of the I should say the invasiveness of the surgery and the extent of the recovery varies a lot on how much of the spine is being impacted by spinal stenosis. So if you just have spinal stenosis in one area of your spine, as opposed to multiple areas, and you don't have any sort of other conditions that warrant something like a spinal fusion, very commonly we could do a lumbar laminectomy decompression surgery as a same-day surgery and let you go home the same day. More commonly, though, spinal stenosis occurs in multiple regions of the spine, and we have to do it through what I would characterize as a surgery of maybe moderate invasiveness, where we open up the back and basically we remove the back covering of the spine called the lamina to open up the spinal canal. We bite away the overgrown bone spurs and ligaments that are compressing the nerves. And often that procedure is done in the hospital setting, and patients might stay in the hospital anywhere from like 1 to 3 nights, depending on, again, the invasiveness of the surgery and their overall health and their mobility after surgery.
Yeah, I like to tell patients that, similar to the example of the narrowed canal, now what you're doing is you are making that canal into a half pipe. And it's like a big 7-foot NBA player in a tiny little convertible. You open up the top to that convertible, and that 7-footer can sit upright and extend themselves and have a lot of room there. That's kind of like the laminectomy procedure, and will provide the nerves enough space so that they're not causing these symptoms either in the back or going down the leg. What kind of options would there be if somebody were to need a fusion, in terms of the conditions that may need that, and what kind of things can you do to best optimize the result for that patient?
Right. So if a patient just has spinal stenosis and nerve compression in the setting of arthritis, we do just this laminectomy decompression that I was alluding to. But there are conditions that warrant a spinal fusion. And one of the most common ones is that condition called the spondylolisthesis on the MRI that we just showed. That patient had instability or excessive or pathologic motion between the L4 and L5 vertebrae. And for that patient, not only do we have to go in and open up their spinal canal to give their nerves more room, we have to stabilize that unstable area. Otherwise, we risk that instability getting worse over time, or stenosis can reoccur in that region. So a spondylolisthesis is a very common reason to require spinal fusion. There are other reasons that we sometimes suggest a spinal fusion. There are some areas of the spine that we cannot get to adequately without doing a spinal fusion. And what I mean by that is, if we just have to open up your spinal canal, we could always do that without doing a spinal fusion. But sometimes stenosis occurs not in the spinal canal, but further outside in the nerve tunnels where the nerves exit the spinal canal. And sometimes in order to get that nerve fully decompressed, we have to remove so many bony parts that we would create an unstable spine. So oftentimes we'll elect to do a spinal fusion in that setting, not because the patient had previous instability, but because the extent of the decompression that we have to do to free up the nerves would cause instability. So we do the spinal fusion to allow for an adequate decompression, because that's always the primary goal, is to make sure the spinal stenosis has been decompressed. And I would say, one of the a final common reason that we consider fusion is if there's a bad deforming, like in a scoliosis or something like that, and we have to address that as well.
Now, patients will always ask, they'll say, oh, I've heard spinal fusion is bad, and should I actually get it? And is it going to be too much? This, that, and the other. So, I mean, is there a lot of good evidence or data that supports, doing fusions?
Yeah, for the right spinal conditions. This is sort of a matter of, what are the appropriate spinal conditions that are best treated with a spinal fusion, and what patient will benefit from a spinal fusion versus in what kind of patient is a spinal fusion unnecessary. And the example I always give to patients is, if you come in with, many years of back pain and your MRI just shows diffuse arthritis in the back, a spinal fusion is not going to reliably get rid of your back pain. We wish it did. Our colleagues in the joint replacement world have a definitive surgery that will cure patients of arthritic hip pain. They replace the joint, right? But we don't have a surgical cure for arthritic back pain in the form of a spinal fusion. And I think in the old days, that would often be tried or attempted, I should say, and was not necessarily met with the best or most reproducible or reliable outcomes. And what we found through decades of clinical studies and research is that that's not a good reason to do a spinal fusion. But what we have found is that spinal fusions work very well in the setting of spinal deformity, in the setting of spinal instability, like a spondylolisthesis, and patients actually have improved clinical outcomes when a spinal fusion is done for the appropriate indications than if they just have a decompression or a laminectomy alone.
That's great. And, then the question becomes, if this is a slightly larger surgery, what is the recovery like for this? How long is somebody in the hospital? And when can they kind of get back to activities like they plan to?
Yep. So not all spinal fusions are created equal. There are different ways of doing that. Sometimes we open up the spine from the back to do a spinal fusion. Sometimes we do a spinal fusion from the back through less invasive or minimally invasive approaches. There are also other less invasive ways to do a spinal fusion where we don't go through the back, but we approach the spine from the side of the abdominal or torso region, or even sometimes we can go from the front. And each approach is associated with a little bit of a different recovery. But for the most part, yes, a recovery from a spinal fusion is more than a recovery from a laminectomy alone or a discectomy alone. Usually these surgeries are done in the hospital setting. Usually patients are in the hospital for a few nights afterwards, usually 2 or 3 nights. The majority of our patients do go home from the hospital and they're mobile and walking and active afterwards. But this isn't the kind of thing that you're fully recovered from in a matter of days to weeks. It's more like, weeks to a couple of months. I'll tell most of my patients you'll be back to most activities of daily living after probably 4 weeks or so. But I tell patients the full recovery is probably a good 3-month process after a spinal fusion.
And then to that point, then, as we talked about with the other topic, do you then initiate some post-operative physical therapy? And if so, at what point do you kind of determine that?
Yeah, so all patients get therapy while they're in the hospital. And the focus of that is not the back, it's to mobilize the patient, make sure you get in and out of bed safely, make sure you're walking safely. Most patients will require an assistive device for the first few days or a couple of weeks or something like that. So it's to get the patient walking and mobile in an independent way so they're safe enough to go home. Once patients go home, there's not physical therapy, certainly not initially. If somebody made you do physical therapy for your back within a few days or a couple of weeks after back surgery, it would hurt, all right? I tell patients the recovery after spine surgery is more of a functional recovery. It's a gradual, progressive return to activity as your pain or level of comfort allows you to progress. So the vast majority of patients make a gradual recovery. We encourage walking from day one, and they don't do formal outpatient therapy. But there are patients who come back maybe 6 weeks after surgery, maybe 8 weeks after surgery, and they're still a little sore, or they still feel maybe their back muscles feel a little weak or deconditioned. And sometimes in a delayed fashion, if we feel a patient could benefit from a little bit of a strengthening program to build up their back muscle or core strength, we do sometimes initiate that in a delayed fashion. But it's a very sort of patient-specific approach only if a patient is in need of it at that point in time.
That's great. And then I guess, one of the things that people will always wonder about is, again, is there some way that they can prevent this from happening, or did they do something to make this happen? And if not, is there something that they can do? Let's say they get over a flare up with physical therapy or something. Is there something you can do to prevent a future one, or to minimize the effects of a future flare up?
Not a ton. Again, not things that I'm aware of. I don't know if you have any further insight, but I encourage patients, in general, habits that promote a healthy lifestyle also promote better spinal health, right? So don't smoke, maintain a healthy weight, exercise on a regular basis, be active, avoid prolonged sitting. Those are things I always encourage patients to do. One thing that's always astonishing to me is I could see two patients in the same day whose MRIs otherwise look similar, right? They have bad arthritis and multi-level spinal stenosis, and maybe one patient is fit, they're healthy, they're active, they have good lifestyle habits, they exercise on a regular basis, and another patient might be overweight, more sedentary. It's very, very common that the overweight sedentary patient is going to be more symptomatic from the same spinal condition than the patient who is more active, maintains a healthy weight. So there's something to be said for the idea of promoting a healthy lifestyle, trying to maintain a good weight, as best as one can. But aside from that, there's not a whole lot else that one can do. I don't know if you have any other thoughts on the topic.
Yeah, I know. When patients ask me that, I tell them, there have been some studies that have done on this, and obviously it's hard to study this because you have to follow people pretty longitudinally for many, many years. But I can think of one study where they looked at a set of twins, right? So twins are genetically similar, and they compared over time, who had more degenerated discs and who had, worse kind of spine outcomes compared to the other twin. And the only risk factors they could really identify was a little bit of weight, was one of the kind of weaker factors. But one of the strong factors was smoking. Smoking will speed up the degeneration of your disc for sure. But even things like, the one example I remember starkly from that one article, at least, is that they compared like exposure to vibration, right? Like one twin is a jackhammer operator and one is not. And still there's no real difference in their spine outcomes when controlled for these other things. So some of it is just genetic, and some of it is not really controlled by your activities or otherwise. If you have some old injury from 30 years ago that started the degeneration of your disc, that's kind of, you've set up that cascade already, unfortunately. There's not really much you can do today to prevent that. So it's just sometimes it's just the die is cast a little bit.
But I will say, taking care of patients with spinal stenosis or spondylolisthesis and spinal stenosis, we like taking care of those patients as surgeons because we know that the outcomes are pretty reproducible, reliable, good outcomes in terms of meaningful improvement and quality of life and the various health measures that we can measure. It can be a debilitating condition when a patient is living with it, but luckily we have good treatment strategies, particularly in the surgical arena, to address this. So again, this was a lady who was in her mid-60s who, as we had shown on the MRI, had very bad spinal stenosis. She had this significant walking intolerance that we were alluding to. She really couldn't stand or walk for more than 5 or 10 minutes or so without having to sit down. She was recently retired, but was not able to really enjoy spending any time with her grandkids. Her husband had to assume most of the household duties of shopping and maintaining the house because she just couldn't do these things anymore. And we treated her with the usual course of therapy, meds. I even think she tried a couple epidural injections, and she would get relief, but it wouldn't be long lasting. She would only feel better for a couple of weeks at a time after the injections. And because this was having such a negative impact on her quality of life, she elected to pursue surgery. So what we did in her case is we opened up the spinal canal. at the two bottom levels at L4, L5. That was the area where we showed you the really bad stenosis. She also had nerve tunnel stenosis at the level below, which we didn't go through, but she had some pretty bad nerve compression there. So we opened up the spinal canal, and she required a spinal fusion. And she actually required the spinal fusion for two separate reasons. The L4, L5 area required the spinal fusion because that was a very unstable area, which we saw where her vertebrae had slipped out of place. And you can see we restored some of her alignment to be partially closer to normal in this fusion picture here. And then the reason that we fused her bottom level was because the nerve tunnel narrowing was so bad. We had to remove so much bone to basically open the roof of that nerve tunnel that we needed to restabilize the spine by doing that. And those are metal cages that we put in the disc space there. And what that metal cage does is jacks the disc open, which also allows the nerve tunnel to expand. So it's another technique to open up the nerve tunnels in the setting of spinal stenosis. So this woman spent, I think, 3 nights in the hospital. She had a drain in for a couple days, but she was up and walking the day of surgery. Day 3, she was able to leave the hospital and go home. Her walking tolerance, even day 1 after surgery, she was already walking better than she was before surgery because her stenosis was gone. And she's like, yeah, the back hurts, Dr. McDonald, but it's not as bad as my pain coming into this. And then the surgical back pain got better after about a few weeks or so.
Well, I want to thank Dr. McDonald for his time today and talking about these very important lumbar spine conditions. If you are experiencing any of these symptoms and would like to come speak to one of the spine surgeons at University Orthopaedic Associates, I direct you towards uoanj.com, and we will be happy to take care of you if you come to our office.